Okay, now let's talk about care of neurosurgery patients in the PACU. So it's as a PACU nurse, it's really important to know, especially if you recover neurosurgical patient, that you need to know the ANP of the central nervous system, bones, and stuff like that. The skull, why is that bones important? You would know where the location of the fracture or maybe a surgical approach. So if it's frontal cranium, you know that cranial approach was through the frontal bone and the parietal bones back here. And then you see a sphenoid bone, temporal bone right here, and a septal bone being back here. So you have approximately have an idea where the fractures were or the surgical approach was. Another thing you need to be aware of is the layers of the brain. And dura mater is a tough and flexible layer that's outside right here. You see that thick white layer right here in this picture? That is your dura mater. And you have a arachnoid right here. See that? Arachnoid, it is a word for spider, right? It's a spider web-like. And you got a pure matter. So that is the layer that's covering your delicate brain tissue and central nervous system, like your spinal cord. It's covering that. It's putting the like tight little bundle. And another thing you need to be aware of are spaces. So epidural space. It is the space between skull and dura. So you see that space right here, the bone, and then you have a dura right here. And then if the bleeding occurs, like epidural hematoma, it happened between the bleeding or the clot is located between skull and the dura mater. So it's right here. So that's where epidural hematoma would form. And you have a subdural. Subdural space is between dura and arachnoid. So you have this dura mater right here, and you have the arachnoid right here. So if you have the patient that, say, for example, like maybe an older patient population, so they have fallen and they might be taking some Coumadin, right? Or hit their head somewhere and had a bleeding and subdural space. So this is where the bleeding occurred between dura and arachnoid. Subarachnoid space is between arachnoid and pure matter. So, for example, if the patient had an aneurysm that has ruptured and had a bleeding that occurred, you're going to see a bleeding in subarachnoid space. So now let's talk about brain surgeries. But before we talk about brain surgeries, let's review those surgical terminologies. So when you're taking certification exam, you don't have to be an expert at every field. So you just need to know where this surgery was done, what kind of surgery it was, and you can kind of guess like what the major complication related to the system is. So for example, if they mess with like eyes and ears, then you know they're going to be nauseated. So that's something that you can anticipate. So let's look at some of those words. So centesis means surgical puncture. So pericardial centesis, put a little puncture to that little space and draw up the fluid from the heart, right? For like a cardiac tamponade. Tripsy, crushing or breaking up. Esthesis, fusion of two parts into one to stabilize. Ectomy, so that's removal. So let's talk about crenectomy and craniotomy. So that tiny little difference means a huge thing. So crenectomy meaning that that's your cranium, right? That is your skull. We removed portion of the skull versus craniotomy meaning that surgical incision to cranium. So that's a huge difference. So OPSI is looking at. Oscopy, meaning a viewing of, normally using a scope. For example, like arthroscope. So they use that scope to look at the joint. Ostomy is a surgically creating a hole. Otomy is a surgical incision. Pexy to fix or secure. Plasty to modify or reshape, like an arthroplasty, that is your total joint, right? A replacement with a prosthesis. So they put in like a metal or whatever, the joint replacement into that joint. So now let's talk about craniotomy. Craniotomy is a surgical opening of a skull. Remember, crani, cranium, autonomy, surgical incision, right? Surgical opening of the skull to gain access to portion of the central nervous system inside the cranium. So why do we need to do craniotomy? We don't just open up a skull to, just like fun of it, right? We need to gain access within the cranium to see something or take out something or fix something. So what are the examples? So they usually do craniotomy with some sort of tumor removal, like meningioma, right? Or glioblastoma removal, cerebral decompression, evacuation of hematoma or abscess, clipping of aneurysm, removal of AV malformation. That'll be the example. So let's talk about the big craniotomy that you're probably gonna see with your tumor resection. When they do craniotomy, the patient will be completely under anesthesia because it does have some pain receptor. It is going to hurt. But once they gain access to the brain, we don't have a pain receptor within the brain. So what they can do is actually wake up the patient to continue doing a tumor resection. For example, this picture right here, if you can see, the neurosurgeon is performing tumor resection while allowing the patient to wake up and play the violin. So they can see she make sure she doesn't lose the fine motor function and all that stuff. She's probably a professional, so we want to make sure she, can continue her job after her surgery. So now let's talk about crenectomy. So remember, nectomy meaning we removed it, right? So it's excision of a portion of the skull without replacement. So why do we need to do crenectomy? The compression after cerebral debulking. And so majority of the case that what I've seen in my experience at my facility is patient who had, let's say, massive stroke or traumatic brain injury and have a massive cerebral edema. And again, the skull is a closed box, right? If it starts to swell up, it doesn't have a place to go but to down, and the brain's gonna herniate. So last ditch effort, they would take off that portion of the skull like that guy right here, take out a huge portion of the skull, allow the brain tissue to swell up. And then once the cerebral edema settles, we'll put the bone back. So that's what I've seen most. Could be used to remove bone fragments from skull fracture, removal of skull growth as well. One thing that you need to be aware of when you receive those patients, well, actually two things. One, you need to prevent injury. So this side don't have the skull to protect the brain tissue. So do not turn the patient onto that side. And if the patient needs to ambulate and whatnot, and yes, those patients will eventually use physical therapy. They need to walk and all that stuff and sit up in a chair. They need to wear a helmet to protect the brain tissue. And one thing that you need to ask when you receive those patients from the OR, you need to know where the bone fluff is stored. Is it in the subcutaneous pocket in the abdomen, or is it in the freezer in the lab? That's something you need to ask. Butterholes. It is a removal of isolated or multiple small circular portion of cranium for purpose of clot removal. So they do butterholes to gain access to, let's say, like subdural space, so they can remove subdural hematoma. So evacuation of clot, removal of subdural fluid, installation of medication, drainage of CSF. Transsphenoidal surgery. So why do we do that? And when the patient have a tumor in the pituitary gland, it's so much easier to access that through the nose, transnasal approach. So they'll put in a little probe to remove the tumor that way, puncture through dura and then get there to remove tumor. So after you receive this patient, you need to make sure nothing goes in the nose. Like if the patient's airway becomes unstable and you want to put in airway, do not put in your nasal airway in there. And so make sure you don't do that and just don't stick anything. And even I'm very careful with anything around the nose, and you're probably gonna have a drip pad under the nose. So you're not gonna put in a nasal cannula or anything like that. If you need to give oxygen, use your face stent or face mask to give oxygen. And the patient should not be blowing nose full stuff. You don't want to cause a tons of pressure in the dura. Remember, we puncture dura, right? And then it's going to cause CSF leak if we cause a lot of pressure there. So and also instruct the patient to sneeze if they need to sneeze with the mouth open so we don't create a pressure. And some of the patient might even come out with a lumbar drain in place so we can get the dura really flat and just let it heal. One thing really need to watch out for those patient population, you need to watch the signs of symptom of DI. So you're checking the urine specific gravity very frequently. And if you see the urine output pick up, you're going to start thinking the patient might went to DI. So check that sodium level there too. So another surgery we do that's just shunt placement. So I work in adult hospitals, so I don't see a lot of pediatric patient coming in to get a VP shunt placed, but we get a lot of those revisions. We might get the patient who had the shunt that got infected, and that needs to be externalized. So what they would do is put in a lumbar drain, and once the infection clears, they would go ahead and put in a new one. So that's something that you see. They put in a little catheter there, and the tip of the tube could be placed in a different area. So depending on where the tip is, you're going to hear a little bit different names. So microradial surgery, what is that? So it is a minimally invasive way to do some surgery. For example, like a gamma knife, it is a precise destruction of deep and inaccessible lesion during single session. So what we once thought was inoperable brain tumor can be reached using gamma knife. It is a weapon. So when you have this gamma knife in your hospital, that they are looking to, I think Homeland Security will come and clear that area to make sure, you're not using it for wrong things. It is for use for AVMs, tumors, or other brain or cervical spine cancer. A cyber knife is a delicate robotic system that can approach a tumor in the brain, head, neck, and spine. Lasers can precisely dissect without traumatizing surrounding tissues. So it's a much more less invasive way to approach tumor and cancer. So let's talk about some of the seizure surgery that we do. So some of the phases you're not gonna see like non-invasive scope monitoring. Those are done on outpatient basis. But when you receive those patients in the PACU, they are in phase 2. So what they will do is they place a depth electrode. So they put in a little you see the little electrodes that goes in the brain, and it'll pinpoint where the lesion of the seizure is coming from. And then once they identify, they come back and get those probes removed, but they will zap that one little area to kind of get rid of the seizure that way. So you're going to see that kind of patient in your PACU. Deep brain stimulators are indicated for like a tremors, like a Parkinson's disease tremor, dystonia, or neuropathic pain. And those are invasive, but does not require extensive monitoring. But often CT of the brain is done on the post of day 1 or day 0. So just to be aware that you need to look for the order and the big risk of those deep brain stimulator or a pneumocephalus, so air in the brain. And when they see that in the CT, often they'll keep the patient on the 100% non-rebreather and try to get that air to kind of shrink. So what are the post-brain surgery payer and seizure nursing care you need to be aware of? It's really important you do a good neuro assessment. I cannot stress this enough. So when you assess patient in the PACU, again, the priority is always your airway, breathing, and circulation. And but some of the surgeries you go checking other things like pulses of the legs and whatnot. But for neuro, you need to assess your neuro well and very often. A neuro patient, when they deteriorate, you're not going to see it on the monitor. You're going to see it on their neuro assessment. You're going to see level of consciousness. So assess, assess, assess. Drain management. So some of the patient might have a ventriculostomy, or maybe they have a lumbar drain. So you need to make sure you know how to manage that. And what is the goal for ICP? Make sure you keep it below 20, right? And do interventions to reduce your ICP in the patient, and know what to do if the ICP is elevated. Hemodynamic assessment stability is again important because brain again is a very greedy organ, and it is going to act up if you don't have an optimal cardiac output. Assess complications such as DI, intracranial hemorrhage, stroke, and any issues related to brain surgery. Seizure precautions important too. So anytime you touch a tissue like a pancreas transplant, your pancreas is going to get irritated, right? Because we touched it. They're going to have pancreatitis after surgery. Brain, same thing. If you touch brains, get irritated and want to try to have seizures. So seizure precautions are important, and often they are antiepileptic medication post-op. CT of the brain is often done on post-op day 0 and 1, so make sure you look at the order from neurosurgeon. General guideline for neurosurgical patient positioning. So really think about the type of surgery they had, and the airway pain is so important. The neuro patient airway, they lose airway so quickly. Monitoring equipment, do you have any lines, tubes, and drains? And that's something you need to be aware of. Generally speaking, keep the head of bed pretty high and maintain a good neck alignment. So really monitor that. And then when you have a patient with your ventriculostomy, make sure you level that to the appropriate level so you are not measuring your ICP incorrectly. And with a lumbar drain too, make sure you are not draining way too much too or too little. So now let's talk about spinal surgeries. So laminectomy, it is the most frequent surgical procedure. Removal of a little bone right here, right? A part of posterior arch of vertebrae. So it's a little, I don't know, sticky portion right here. A hemilaminectomy, meaning a excision of a part of that. So half of that, right? And then why do we do it? To decompress the spinal cord or nerves. You see that right here in this picture? It is so compressed, and then your spinal cord is so angry. I might have pain, might have numbness, tingling, and all that stuff. And if we remove that pressure, now your spinal cord can expand and won't be so angry. An approach could be anterior or posterior. So like a cervical one, they might do anterior approach. So when you have a patient, anytime you have a patient in any neck procedure, airway is so important. You're gonna look at the edema and look at the, do you have any spinal tracheal deviation? It could be a hematoma. So you really need to look at that. Can they breathe? Okay, airway pain, all that stuff. Discectomy, removal of herniated discs. So again, it can be done in the lumbar or cervical, and it can be, again, posterior anterior approach, for especially for like neck. Microdiscectomy uses microscope to take off the disc. That's pretty cool, right? Percutaneous discectomy, so it gets smaller and smaller. Your endoscopic lumbar surgical technique. So why do we do this smaller incision now? So patient have less pain. They would walk more, right? So they have less complication and they get to go home sooner. So it's really a win-win for everyone. Spinal fusion. And you probably have recovered some of your spinal patients. They hurt so much, right? But spinal fusion is another one that is very painful. So insertion of bone chips between vertebrae and variety of surgical hardware, like rod, screw, bolts, may be used to kind of stabilize that. Purpose is to immobilize the vertebral column. It could be lumbar, cervical, and again, cervical could be anterior approach. So really look out for the anterior cervical discectomy and fusion, a very common surgery that's done. Again, anytime go through the front of the neck. Really, the airway management becomes so important. So let's talk about other surgeries that we do. For crenectomy, that's your surgical enlargement of intervertebral foramen to accommodate exit of spinal nerves. And another one is rhizotomy. So destruction of sensory nerve roots at the entrance to spinal cord to interrupt transmission of pain. So it is done for your pain management patient. So spinal surgery, not just for your like a laminectomy, spinal fusion, it's a lot to do with the pain management too. And if you think about those patients, they have been taking some pain medication for some time too, so they might have some tolerance there as well. Cordotomy, so that's pain pathways transected at midline portion of spinal cord before impulse, in a sense, through spinothalamic tract, interrupt transmission of pain. Another procedure for your pain management. So generalized spine surgery, pain anesthesia, nursing care you need to be aware of. You might need to do a specific spinal cord assessment, and neurovascular assessment becomes really important here because we deal with spinal cord. Assess for signs of meningeal irritation such as headache, photophobia, rigidity. So if their neck is stiff and oh my gosh, it's so bright and I have a headache, so you have a meningeal irritation. And again, hemodynamic assessment stability is important. Assessment of airway, especially with anterior approach. Urinary retention might be seen often with a spinal surgery, so assess that. And follow your facility protocol, but just because they have a urinary retention initially doesn't mean that they're gonna have it forever, and it could be related to anesthesia too. So follow your protocol, and you might be doing straight cath initially, and don't go straight jumping onto the gun and put in follow, because CAUTI is another reason the patient can have sepsis and die and stuff like that. So we want to have less lines, so make sure you follow your protocol. Pain management becomes important again. Like I said earlier, they're very painful procedures. So pain management is important. You might be working together with a pain management services to manage their pain. Positioning, so roll the patient, don't be twisting their spines, and assess the skin integrity. And any long surgery for that matter, it's really important to assess the bony prominences, make sure they didn't develop pressure injury. DVT prophylaxis to put on the STDs, and if they have order for TADs, order for chemical prophylaxis, administer that. So monitor for complications like motor loss, urinary retention, paralytic ileus, CSF leak, hematoma formation, infection, spinal cord injury related issues. So let's talk about the very rare things that could happen, like spinal shock. It's a condition occurring immediately after injury. It might last hours to months, often seen in a spinal cord injury, like your trauma patient. Characteristics, you see a loss of motor, sensory reflex, and autonomic activity below level of injury. Flaccid paralysis, all skeletal muscle. Loss of pain perception, like touch temperature, pressure below level of injury, and a loss of ability to perspire. Absence of somatic and visceral sensation, and bound and bladder dysfunction, hypotension, and bradycardia. And what follows spinal shock could be autonomic dysflexia. So usually occurs after resolution of spinal shock and reflex activity, and occurs most often with a lesion at T6 or above. So it is a condition that emerges after spinal cord injury, and usually when the damage has occurred above the T6 or higher. The higher the level of spinal cord injury, the greater the risk. Dysregulation of the autonomic nervous system leads to an uncoordinated sympathetic response that may result in potentially life-threatening hypertensive episode when there is a noxious stimuli like your full bladder, right? Below the level of spinal cord injury. In about 85% of cases, the stimulus is from like urological sources like UTI, distended bladder, or clogged Foley catheter. There's a significantly increased risk of stroke. It's very surprising, 300% to 400%. Autonomic dysreflexia can occur in susceptible individuals up to 40 times per day. That sounds miserable, right? So the symptoms, pounding headache, it's very severe pounding headache, hypertension, change in mental status, seizure, stroke, bradycardia, profuse sweating, flushed skin above the level of lesion, nasal congestion, pallor and pyrorexia below level of lesion, anxiety, visual disturbances. So how do we treat it? This patient, just remove the stimulus. So if the bladder is full, the flow is clogged, fix it. Elevate the head of bed, notify MD, treat hypertension with fast-acting antihypertensive medication. So that covers your neurosurgery patient. I hope you got some hint on how to recover those neurosurgical patients. Thank you for listening.